positive symptoms are things that normally would not occur. So they're normally not present. So the first one being delusions or hallucinations, altered speech, and bizarre behaviors. So in other words, if I came across Ashley, she should not ever be displaying any of those things. Okay? The negative symptoms are things that could normally be present. So could I come across Ashley at some time and she have a flat affect? Sure. She might be depressed. She just might not be having a good day, and so she doesn't have a lot of emotion to her. Allegoria, mumbled or vague responses. Well, good God, I get those from my kids every day. They're not into big, long explanations. In fact, they usually are giving me the what for if I ask them for too much information. And ergia, no energy. Well, you work a lot of hours, you have families. I would say at some time or another, you probably could say that you have that symptom. Anhedonia, lack of joy or pleasure. There are times in a person's life when you might have a little bit of mild depression or something, and you just don't have that joy or pleasure in your life, or find something, you've lacked that in a certain thing that maybe you used to enjoy. Maybe you and your mother used to always knit together, and your mother passed away, so now you don't participate in that anymore. Again, that's a normal thing that possibly could happen. Avolition, this is lack of motivation in activities or hygiene, and we see that on occasion, as long as it's not to an extreme. If you saw somebody that was dirty or their hair was matted, something like that, I would say that would be a very abnormal thing. But like I say, keep in mind the positive and the negative, and you'll have to know the difference between the two. So the question might say, they're exhibiting these positive behaviors, which ones are those? They're exhibiting these negative behaviors, which ones are those? So just keep in your mind the difference between the two. Okay, a little bit of demographics then on schizophrenia. The onset can be abrupt or insidious. Oftentimes, once you notice that a patient has had a schizophrenic break, you can look back and say that they probably have had issues at various times throughout their life. It never transcribed into a full-blown schizophrenia where they had a lot of those negative or positive symptoms, but when you look back, there's been some issues. Usually we say late teens to early 20s are the more typical. Some of you are in that age range right now, and as you get older, you'll find that there's going to be more stressful things in your life, but this is a big change. Oftentimes you go to college, or you start a career, you start a new job, maybe you move out of your parents' home, maybe you establish a relationship with a significant other. Those are stressful times in your life, and oftentimes we will see some type of break in that age group, and they'll have a schizophrenic break, and they'll have schizophrenia then from now on, and hopefully we can catch it early and get on medications and resolve it to the best of their ability. But that's about the time that it happens. Your book does talk about that it can happen earlier in childhood or sometimes as a later adult, but the more typical time is that late teens to early 20s. So we see a lot of schizophrenic breakdowns, especially when people are away at college or they're adventuring in something in that early 20s that's new and highly anxious in their life. Okay, the next thing is diagnosis and then some outcomes. So they have to have greater than 6 months of this psychotic thinking or this abnormal behavior, and they have increased positive symptoms. And remember, those positive symptoms are those hallucinations, delusions, altered speech, and the bizarre behaviors. So you may notice a few things, but they're increasing in their nature. The outcomes for these patients then, short term, there's a couple patterns that the patient can take, ongoing, and they never fully recover. So we have a guest speaker. Unfortunately, she couldn't come before your exam, but we have a lady coming from NAMI that is just wonderful, and she's going to come on the next couple of weeks. I think the 30th, October 30th maybe. And she's going to talk about her brother and his schizophrenic break and how he's doing in life right now. And she'll give you a good picture of the patient who really never fully recovers. And then patients can have some episodes of complete recovery where they actually do pretty well. Long term, hopefully the psychosis does decrease over time. Most, however, don't really live up to their full potential. They don't really live full independent lives for a prolonged period of time. Like I say, they have episodes where they can manage. She'll talk about her brother having a girlfriend and stuff, and then had another trigger in his life that threw him back into disarray, and he never really fully recovered the second time from it. So again, these folks have a lot of triggers, a lot of things that they deal with, and depending upon their support system, they may never be fully independent again. Some related disorders that your book talks about, one of those is a schizophreniform disorder. The duration is usually about 1 to 6 months. They can have a delusional disorder where they have delusions that can last a little greater than 1 month. They can have a brief psychotic disorder, anywhere from 1 day to 1 month. And then a schizotypical personality disorder, the problems with self and interpersonal relationship, and it's not quite as severe then as having true schizophrenia. So like I say, you can read over those in your book. You'll hear people talk about the different disorders that they have, and these are just not as extreme forms as having a true schizophrenic break. And the time periods differ just a little bit, and I think that's, again, how they can diagnose the different types also. Etiology, so what causes it? There are some theories. One of those is a biological theory. So we believe genetics plays a role. If you have an immediate family member, like a sibling, mother, father, something like that, that has it, there is some inheritance piece to it. If you are an identical twin and your twin has schizophrenia, you have a 50% chance of having schizophrenia. If you're a fraternal twin, you have about a 15% chance. So there definitely is a very strong genetic link related to schizophrenia. Anatomic and neurochemical factors. There's some theories that go on the fact that we have less brain tissue, possibly these folks do, and they're lacking a little bit of cerebrospinal fluid, which causes the issues. Or there can be issues with dopamine excess and serotonin changes that cause an excess amount of dopamine within the brain that can cause some of these factors. There are some immune or virologic factors that they say maybe you've had a viral exposure, and then you have cytokines, and they elicit a immune or inflammatory response. So there may be some changes there related to some virus that you've been exposed to that they think can trigger your schizophrenia. Like I say, probably the biggest one that most people will look at will be the genetic piece, because if you have a family member that has schizophrenia, probably your biggest fear is, did you cause it? Did they get it from you? Those kind of things. So especially as a parent, you would want to know what could you have done different to maybe not have this happen to your child. There are some cultural considerations. We have cultures out in the world that look at things a little differently than how maybe we view things that are going on. There are some ideas that consider delusional activity in one culture is very highly accepted. So they wouldn't see it as any type of schizophrenic break. Auditory or visual hallucinations sometimes are part of certain religious experiences in certain cultures. And so having those auditory, something talking to you or you visually seeing something would not be abnormal. They would say, oh, great, you were spoken to or you visually saw this. Culture-bound syndromes, these are things like where they believe in magic or maybe evil spells. I'm thinking maybe people that believe in voodoo and practice voodoo might come into this particular realm also. And then ethnic differences in their responses to psychotropic medication. So, we look at the people around us and we think everybody is like us, but in the end, we have so much integration of other people from other countries and cultures that these are some things that when you're doing your assessments and the psychologist or the psychiatrist is doing their in-depth evaluation, these will be things that they may ask. What is their religious preferences? Do they dabble in any type of magic? Those kind of things that would possibly interfere or give some explanation as to why they might look like they have schizophrenia. Or why they accept their schizophrenia and they really don't seek out treatment because they believe it's a natural piece. So then the next thing that we focus on is how do we treat somebody that has schizophrenia? Well, the first generation medications like haloperidol or Prolixin, and you have a list of medications in your book. There's all kinds that they can give. There actually are medications that we can take PO, sub-Q, or IM. And at the very bottom of that screen, you can see I have depot injections. Depot injections, there's 6 medications that they can give IM, and they go to the physician's office or the practitioner or wherever they're going for treatment, and they get these injections, and they can last anywhere. Your book talks about maybe 2 to 4 weeks, but 4 weeks would be great. The lady who's coming to speak will say that her brother is on injections and they've been a lifesaver because you can see compliance would be great. I think of Depo-Provera, the implant in the back of your arm. Think of birth control, how easy it is just to forget about it. You get the implant, you don't need to worry about taking a birth control pill every day. This is kind of the same philosophy here with the IM injections, is that you take it once every month. You don't have to worry about taking pills and compliance with medication. So that has helped a lot of our schizophrenic patients maintain a more stable mood and stuff by having those options. So some nursing considerations when they're taking these medications is that they do cause a lot of dryness. So we do encourage them to drink plenty of fluids. We can encourage them to chew gum to help alter that dryness in their mouth. And we try to recommend sugar-free items. If they're not big water drinkers, try to do drinks that are sugar-free because we don't want to have a lot of weight gain with this. And then the other thing that some of these medications can cause is a postural hypotension. So we want to tell them to be careful with rising very quickly. They want to sit at the side of the bed, especially if they've been lying down, so that they don't pass out when they rise. One other thing that I want you to consider here for the medication clozapine, C-L-O-Z-A-P-I-N-E, clozapine. Clozapine in some folks can cause an agranulocytosis. Agranulocytosis. It's a lack of WBCs, and it is a life-threatening problem because they have no defense to infection, those kind of things. And it is specifically for clozapine. I should have added that to the slide, but I didn't, so I want to make sure that you know that. So clozapine, it causes agranulocytosis. It's a lack of WBCs. The bone marrow cannot produce those. and they are very high risk for infection, and they have a high percentage of death when that occurs. So if you would notice a high fever, anything like that, we would want to go and seek out physician help right away, especially with the clozapine. And they would be told this: if you could put on this medication, it's highly effective, but that is one of its very severe side effects that can happen from it. Okay. Second generation treats both the positive and the negative symptoms. So here's your risperidone, your clozapine. Those medications come into play here. They're kind of the pines and the dones. There are some other ones. Your benzodiazepines are in another category of anti-anxiety medications, but for the most part, most of our pines and dones are treating some type of psychiatric disorder, whether it be anxiety, antidepressants, antipsychotics. The nursing considerations for these medications are weight gain. So again, when this lady comes and talks about her brother, she'll tell you about a significant weight gain due to the medications that he's on. Sedation can occur, sleep disturbances. There's your agranulocytosis. And that's specific for your clozapine. So we have first generation, and they take care of the positive symptom, that's your delusions, hallucinations, etc. And then your second generation treats both your positive and your negative symptoms.
Wait.
Some additional treatments: there's your antidepressants, your benzodiazepines would be your anti-anxiety medications. So you might have a combination of medications that these patients are on. And we want to do the least amount possible because they all have side effects of taking them. So we want to get by with the least amount of medication possible. All right. So we talked about some basic side effects: dry mouth, postural hypotension. Obviously, the agranulocytosis is nothing to sneeze about, but there are some other neurological side effects that you will need to know, and the one being your extrapyramidal side effects. Acute dystonic reactions, those are spasms of the neck, eyes, even the laryngeal airway. So spasms of the neck or eyes, laryngeal spasms can block off the airway. They're very painful when they have those spasms, and it's very frightening for the patient to have that occur. Okay, so spasms of the neck or eyes, laryngeal spasms can block off the airway. They're painful and frightening for the patient. Akathisia, these are pacing or restless behavior. And then for Parkinsonian isms, these are just like a Parkinson's patient. They will shuffle, they have the mask-like facial expression. So shuffling, mask-like expression, face mask-like facial expressions. The next one is tardive dyskinesia. These are a little more late appearing. They have abnormal involuntary movements, like lip smacking, chewing, blinking. So late appearing, abnormal, involuntary movements like lip smacking, chewing, blinking. They can have jerky or writhing movements. Once they have those, they really don't go away. They can decrease once the medication is discontinued, but some of those symptoms will still stay with the patient. So stopping the medications or changing them can decrease the symptoms, but for most of them, they do stay with them. They're embarrassing type movements. It causes a lot of social isolation because they're embarrassed by it. So we teach patients to watch for those small things to start out and get a hold of the physician right away if they notice those. Seizure activity, your book talks about, it's very minimal. Not a very large percentage of patients have seizures with the medications. And then neuroleptic malignant syndrome. This is a frequently fatal condition. So it doesn't happen frequently. I want you to write it correctly. But when it does happen, it oftentimes is fatal. So when it happens, it oftentimes is fatal. They have muscle rigidity, high fever, high leukocytes, and an increased CPK. So we're looking at a fever like 102, 103, and for an adult, that's pretty high. So muscle rigidity, high fever, so like 102, 103, increased leukocytes, and an increased CPK. Like I say, doesn't happen a lot, but if it happens, it is often fatal. So your spike attempt, anything like that, when you're on your medications, we would want to let the doctor know, especially if you don't have any other symptoms related to it. You don't have a cough, anything like that that might be causing you to have a fever. You can already see when we're taking antipsychotic medications or any of these medications for mental health disorders, good education on their medications is important. So the more support system that they have, the more the family's involved, the better response they're not only going to have for compliance, but if any of these things show up, we can get medications changed early so that they don't have any lasting effects. Excuse me. Psychosocial treatment. So they kind of repeat themselves for almost all of these disorders, but individual therapies, group therapies, the more interaction you have with other people with the same disease process gives you better support, makes you more compliant with your medication management, community support systems. NAMI is a great mental health support system out there, especially for families, because families have a lot of questions concerning their daughter, son, husband, wife, whatever that may have the disorder. They can answer a lot of questions, can get them in touch with different support groups, psychologists, psychiatrists, etc. We're a little lacking in our mental health support in the Richland County area. Your bigger cities tend to offer a little more to the patient, but NAMI is a great resource person to be able to help for any of our surrounding areas. Social skills training, they lack social skills. When you look at some of the disease process, the symptoms and stuff that go along with it, if I told you, Mallory, that I was having hallucinations and I saw whatever, how would you react to that? Because you're looking around and you don't see anything. So are you going to treat me the same when I say I see things and they never go away, even though I'm taking medications? There's a lot of social isolation and things that you keep to yourself with being schizophrenic, because people are not, they don't mean to, but they're probably going to treat you a little differently once they know you have schizophrenia. Cognitive enhancement therapy, those they practice and develop social skills. How do you interact with people? The cognitive adaptation training, for that one, they work on home skills. Calendars, signs, things that will just help you manage your everyday life within your home. And then for the enhancement therapies, your book talks about they practice and they work on their social skills so that they can get out and hold a job and go to college and have a relationship and those kind of things. And then family therapy and family education. Both of those things, it's important for family to have some type of resource where they can discuss the family member's diagnosis and treatment and progress without the patient actually there. Family education, it just helps diminish negative effects of schizophrenia. It helps decrease relapses. If your family's more accepting and helping of it, I guarantee you that the patient with schizophrenia will do way better when they know they have a safe place that they can go where their family is accepting and understands what's going on with them. Schizophrenia and nursing care. So what are we looking at with schizophrenia? Well, previous history of schizophrenia. Do they have any previous suicidal ideations? Again, when you're having hallucinations or delusions, what kind are you having? Is somebody voices telling you to do something, to harm yourself? So you want to assess all of that. Their current support system, and then the patient's perception of their current situation. How do they view themselves and what's going on? Then you're going to look at their general appearance, motor behaviors, speech. And then how do you deal with a client with schizophrenia? Well, we need a safe, structured environment. We need to try to maintain therapeutic communication. We have to establish trust, because I'm sure they're going to be very suspicious of us. Assessing for hallucinations and delusions, address them directly. We don't argue or agree about what they're hearing, seeing. I don't hear anything, but you seem to be frightened. So you validate what they're going through, but you don't agree that you hear it or you see it. And we're not going to argue. I don't know why you're so upset. I don't see anything. You can't be seeing anything. There's nothing there. That is not helpful to them. Do not agree with their delusions. You could say, I don't imagine the president would want to kill a citizen, but it must be frightening for you to believe that. Instead of saying, are you kidding me? There's absolutely no way that the president is going to kill somebody. Okay, this is validating that you get what they're saying, but you put a reality spin back on it too. It puts it back on them. It must be frightening to believe that. So those were just a couple examples there on how to communicate. Assess for paranoia, because when we talk about certain personality disorders especially, we'll talk about harm to themselves. Do they have any suicidal ideations? And then we go into what's their plan, how lethal is it, etc., if they would have that. Assess for command hallucinations. This might be something, a voice telling them to harm themselves. Reality-based subjects, we don't engage them on their delusional or hallucinations. We want to keep our conversation in reality, something that's cognitive, that hard, that they can grasp right now. Be genuine. We would encourage them to take care of themselves. We encourage them to participate in self-care and ADLs. Of course, medication compliance, because we need to have them on medication so we can get rid of those positive symptoms. And then family always plays a role. Family is whoever they consider their family. Do remember that. Family does not need to be a blood relative. Family can be who they live with, who they socialize with, okay? But we want to involve them because the more that they understand it, the better the patient will hopefully respond. Elder considerations, usually a late onset would be after the age of 45 for them to have a schizophrenic break. A lot of our psychotic symptoms later in life tend to be associated with severe depression or dementia and not necessarily schizophrenia. So we would evaluate our older adult that's maybe having some of these negative symptoms more related to some other neurological issue going on than we would to say that they have schizophrenia, but they may look like they're having a schizophrenic break.
Mrs. Musak,
Yes, ma'am.
is it 45 like the slide shows? In the notes it says 65.
Oh, it's 65, honey. Sorry.
Okay.
I'll change it. I'll make a note to change the slide. Some things get past me. Yes, 65, because we know that dementia can happen early in life, but it's fairly rare for it to be cleared down at 35. Okay, so the 65 is the age. All right. Mental health promotion then, the goal obviously is recovery, or as much as a recovery as we can get for them. Accurate identification for those people that are at risk for schizophrenic breaks. Early intervention, prevention of social stagnation or decline, and then our second one is prevention or delay of progression into their psychosis. So the more we let those negative symptoms go, sometimes the worse that they get for folks. So when we can catch things early and get them on medications and get them back to a reality state, hopefully the better recovery that they will have. All right. Some other things. So when we talk about altered thoughts or delusions, there are several types. We have thought broadcasting. Those, they believe that other people can hear their thoughts. So if I'm schizophrenic and I'm having thought broadcasting, I believe Haley can kind of like read my mind and know my thoughts. For thought insertion, they believe that their thoughts are somebody else's. So they're inserting somebody else's thoughts into their own mind. And then for magical thinking, they believe they can alter outcomes. Kind of like Bewitched, I'm really doing my age, but wiggle your nose and I can change whatever. It's magical thinking. They believe they can alter the outcome of certain events. So thought broadcasting, they believe that their thoughts can be heard or known by other people. Thought insertion is they believe their thoughts are somebody else's. And then their magical thinking, they believe they can influence an outcome. Alterations in speech, flight of ideas, each sentence is a different topic. Neologisms, the words are made up. I tranged and flittle. And those aren't words. They make up their own words. Echolalia, they repeat words that are spoken to them, so they just mimic it back. You might have kids that do that. Repeat their siblings, and then they're starting to punch each other because they're like, stop repeating what I'm saying. But this person is doing it not because they think it's funny, because they just can't help themselves. Clang association, meaningless rhyming, fox, box, locks. Word salads, words jumbled with little meaning to the listener. Hip hooray, the flip is cast and the wide sprinting in the forest. So those are some problems with alterations in speech. Everybody get those? You're still working. I'm watching Haley write. And your book talks about some other examples too, but those were some that I got out of a book. Personal boundary difficulties is another thing that they deal with. So depersonalization, there's a loss of self. They don't feel real anymore. Or derealization, the environment has changed. Things are shrinking around them. And your book gives some other examples, but those are other issues that they deal with. Altered thought processes are the delusions, and there are some specific types of delusions that your book mentions also, the alterations in speech, and then personal boundary difficulties. I'm going to stop sharing for a minute, and I'm going to see if I can get